Good evening, everyone. Good evening, good evening, good evening.
Good evening, ma.
Good evening.
Good evening.
Good evening, Dr. Ada. Thank you so much for joining, and thank you so much for joining on time. I think we're about 6. I think after, when it's 4:02, we are going to kick off. It's 4:01 right now where I am. Can you hear me clearly?
Yes, I can.
Yes, yes.
Thank you. Let's give a minute more grace. All right, fine. It's 4:02 by my time. So good evening, everyone. My name is Dr. Titilope Ajepe, and I will be moderating today's meeting. This is the March 2022 edition of Hangout with Dr. Ada, and we're excited to have everyone with us. Very shortly, I'm going to bring up Dr. Ada herself. I believe she's where she tells us, okay, I can see her. So where she tells us what actually battered this wonderful hangout that has helped a lot of people, that has bridged the gap really between the doctor and the patient. So I want to welcome us. I promise, or we promise, myself and the team, we promise it's going to be an exciting time. It's going to be a time where you learn quite a lot. Usually I always attend with my biro and the jotter, and I will ask you to do the same, because you're going to be getting from our wonderful resource persons new things you are going to, things that you probably didn't know before that will be useful for our health. So I'd advise us to get our biros and jotters ready. So as the talk goes on, it's always good for you to jot down your questions. We have quite enough time for question and answer. Today, we know that the topic is going to generate quite a number of questions, so it will be good for us to get them down as they come to our heads. So I welcome everyone once again to this meeting. Thank you so much for making this a date with us. I thank you for attending the previous ones, if you have been attending before, and if you are new, we welcome you into our midst. Thank you so much for joining us. So right now, we'll hand over to Dr. Ada. She's going to tell us exactly what Health Hangout, what it is about. I used to tell her that it's a vision that the Lord has given to her, and I believe that you know, she's actually impacting lives with this. So let's welcome her to the floor. So Dr. Ada, tell us what is Health Hangout with Dr. Ada.
Okay, thank you for this opportunity to discuss Health Hangout with Dr. Ada with us. Please, first of all, I would like us to send reminders to our friends and family members. Not so many of them are present yet. Our first speaker is already waiting. Dr. Tobechi Njoko is already here. He's a friend and a colleague, a consultant obstetrician, consultant obstetrics and gynecology from UNTH. He's already waiting for us. He's in short, all the speakers here have a lot to offer us. So please kindly send reminders on all the WhatsApp groups to your family members and friends. There is a one-click link for those who are not very conversant with Zoom. You can send us. It will help us so that whatever information he's going to pass after me can reach so many people. And his is very important. Yes, we need to get that message. Yes. So that being said, Health Hangout with Dr. Ada. I think this forum started October 2021. It was just like a passion prior to this time. Sorry, also kindly mute your mics so that there'll be no interference. So prior to this time, I had been doing some of these health talks in different organizations, churches, youth groups, and so on. It's something I love doing, because if you go on the streets of Nigeria, you realize that information is everywhere. The only problem is that misinformation is so much. Not just that, there are a lot of fake doctors, fake health professionals all over the country. And our people really don't know the difference. So a friend of mine asked me, a colleague, a senior registrar in pathology asked me, why do you have to have a meeting to educate people when they can actually Google online and get whatever they want? And I asked him, how do they know if what they're checking online is genuine, if they are not getting it from the health professionals themselves? Of course, he couldn't answer that question. He agreed that this is a good platform. Apart from that, we've been getting very good feedback. So sometime in October, maybe like some months before then, I noticed that a lot of patients come in with breast cancer during my fine needle aspiration cytology clinics. I am a pathologist in training. I'm a senior registrar. So I hardly really see patients. Most of what I do is to perform autopsy. Of course, during autopsy, I also notice a lot of preventable deaths in Nigeria. Another thing I do is to look at specimen from surgery, which we call histopathology, analyze it and tell what is going on. Is it a cancer or not? Whether it's a cancer or not, I also need to tell the type. And that guy is a clinician, and that is why a pathologist has to be a doctor in the first place. The third thing I do is fine needle aspiration cytology, and then of course, the other parts of pathology is forensic medicine and so on. So during the clinics, I noticed that a lot of patients, please kindly mute your phones. A lot of patients come in with breast lumps that are so big, you know, and some come in with lymph node metastasis already. It was worrisome. It bothered me until some of my close friends or associates, so to say, also presented with such a thing, and some of them had cancer. And recently, quite unfortunately, a patient of mine, 29-year-old, as at the time I met, I think 2 years ago, very beautiful lady. In fact, she could go for a mother of two already, you know, presented also with, I think, stage 3 breast cancer already, you know, and then they started treatment. Somehow we got along. I encouraged them to start treatment and all that. But, you know, the problem with cancer is that when you present late, it's already a problem. Okay. Unfortunately, last month, the husband sent me a message that my beautiful wife is dead. So I don't know, if you are in my shoes, how would you feel? And some of these things are preventable. And I realized that a lot of patients can't even do self-breast examination. So I started examining their breasts and teaching them how to do self-breast examination at the clinic. But with the way the country is at this point, a lot of doctors have left the system, so there's really no time. In my department, for instance, we used to be about 19 to 23 resident doctors. As of today, we are only 5 resident doctors. So I can't teach everybody self-breast examination at my FNS clinics again. So we decided to form this forum and educate my family members and friends. You know, it would be so bad if a relative calls me and says there's a lump here, and by the time we look at it, it's cancer. I want to prevent that at all costs. So that was how we formed this. The first meeting we did was self-breast examination. I taught on how to do the self-breast examination. I did it. Sorry, I'm trying to manage my time. I did it in a hurry. And then we did the repeat where I had to design a breast model. Some of these things are already on our YouTube channels. Hopefully before the end of the meeting, we'll share all our social media platforms. Please, as you join the meeting, kindly mute your mics, especially for other speakers. So we did that and we got positive feedback. We recently had free breast cancer screening in Luth. I want to announce to you happily that of the attendees at that free breast cancer screening, about 15 of them came through this platform, you know, and a lot of patients have also come to say, I have this problem, I have that problem, and at a health hangout with doctor that we refer them at no cost. That is part of what we are doing. So some of my friends and family members caught this vision and took it beyond where we are, where I, you know, envisioned it to be. They started spreading it to different people, and people started asking, can I invite this? Can I invite that person? Of course, I can't say no. So that is why we got to this point. We have people who have volunteered to run the platform, and very soon you'll be seeing more of our volunteers. We're also calling for more volunteers. And then we have people who have, you know, offered to register this as an NGO. So I have a clip of how far we have come. I'm going to also take a talk later in the day because two of our research persons are unavoidably absent. So I'm going to take a clip, a presentation for one of them. And before that, I'm going to share part of what we've done and how far we've come. So once again, I want to welcome you to Health Hangout with Dr. Ada, and I want to thank you for being part of this. Thank all the volunteers and all the resource persons. They talk to us at no cost, you know, and all the participants. Without you, there will be no platform like this. Thanks for coming, and please kindly share our link. We are going to post the one-click link again so that you can share it on your WhatsApp status, share it on your to your family members and friends. Please let them join this meeting. They will thank you after this. We'll share more of our testimonies from this platform as time goes on. Thanks again for coming, and thanks, my moderator.
Thank you so much, Dr. Ada, for that expose. We are grateful. And like I always say, keep the fire burning. All right, so right now, we would like to introduce and invite to speak our first speaker. His name is Dr. Njoku Tobechi. He's a consultant obstetrician and gynecologist from the Nnamdi Azikiwe University Teaching Hospital, Nnewi. He's a gyne oncology specialist. You would agree with me that we have brought to you people really in that specialty. So you can be sure that information you are getting today is right from the horse's mouth, like they say, they are correct. All right, so he's a research enthusiast as well. So he's going to touch on different angles by which we can prevent gynecological cancers. So let us welcome to the floor, Dr. Tobechi Njoku. Thank you so much, sir. It's good to have you. I'd like to ask, should I share your slide or you do that yourself, sir?
Anyone is fine. Thank you very much for welcoming me on this platform. I hope you can hear me. Can you hear me?
Maybe you could speak a bit louder, sir.
Okay, know what to do. Okay, is it better now?
A lot better.
Okay. Thank you very much for welcoming me to this platform. I want to say kudos to the team, headed by Dr. Ada, who's a very good friend and colleague of mine. I'm happy to be here, I must tell you. So yeah, you can go ahead and share my screen if that's fine.
All right, thank you. Oh, yeah, please, can you enable me, Dr. Ada?
Yeah, maybe I could just...
Okay. So I'll make you host. The problem is that you have to admit members. Yeah. So you're the host now.
All right. Okay. Can you see my screen? I'm so sorry for the delay. My system decided to hang right at the moment. Can you see my screen now?
You can.
Yes, I can see, yes, I can see, that's fine. Yeah.
can go ahead, sir.
Okay, fine. That's great. Thank you very much for enabling the screen to be seen. I hope I can see the head very well because I have only 5 minutes to go. Can I be heard?
Yes, please.
Oh,
Okay. Good evening, everybody. If you're in Nigeria, any other part of the world you are, yeah, you're welcome to this platform. My name is Tobeti Njoko. I'm a consultant and gynecologist. I work in the Gynae Oncology and Effective Care and Research Units of Fernando Azikiwe University Teaching Hospital, Nnewi, Anambra State. So I'm here to present the prevention of gynecological cancers. And how about in 5 minutes to do that? So I'm going to keep it as simple as possible, just so our audience would get a grasp of what we're talking about. Can you change the screen, please? Can you move the slide? Okay.
I'm actually trying to do that. I don't know, my system is hanging. So.
we lost Dr. Njoko. Maybe it's the network or something.
I'm still here. Can I still be heard?
We can hear you. Just continue. We may do without the slide, doctor. The time is going.
Okay, fine. Great. So I'm here to do prevention of gynecological cancers, and we all know what cancers are. I mean, it's like when someone hears about cancer, it's like, you know, one of those things you actually don't want to hear in your life. So it's becoming pretty rampant, quite common. Most of the cancers, especially as it has to do with gynecological cancers. By gynecological cancers, I mean cancers that affect the reproductive tract of a woman. So we're talking about the womb, the ovary, the fallopian tubes, the cervix, the vagina, and then the vulva. These are the parts of the body that we call the genital tract of a woman. So any cancer involving any of these organs, we call, so any cancer that starts actually, that takes off from this point, we actually call gynecological cancers. So it could be that of the cervix, it could be that of the womb, it could be that of the ovary. For the sake of this presentation, we're going to deal mostly with the cervix, the womb, and the ovary, because they're actually a lot commoner and actually much more topical. Okay. So by way of explaining a bit further what prevention means, we understand prevention as avoiding something, trying to stop something from happening. But for the avoidance of doubt in medicine, prevention can actually come in three points you can look at it from. One is primary prevention, the other one is secondary prevention, and then we'll have what we call tertiary prevention. So primary prevention is that you don't even want it to surface at all. I mean, you don't want anything to even start at all. You don't want the cancer to start at all. What are you going to do to prevent the cancer from starting at all? Okay, I can see the screen now. Maybe we'll just move to the next slide. Right. So I've made this introduction earlier, but I would like to say that cervical cancer is one of those cancers that's actually a big problem to Africa. It's the leading cause of gynecological cancer death in African women. So you can see it's quite a challenge for us. Unlike in the developed world, where they've actually conquered the incidence of cervical cancer, while they have conquered that, they still have a huge challenge and a huge gap in preventing and managing cancer of the womb. So in Africa, we have cervical cancer more, and in the West, Europe and America, North America, they have more of uterine cancer. Why they do that, they also have an ovarian cancer, which is actually the leading cause of genital tract cancer death in the US. While in Africa, Nigeria, cervical cancer is the one we actually have, a whole lot to handle. Next slide, please. Okay, so like I said before, primary prevention, we have prevention at 3 levels: the primary level, secondary, and at the tertiary level. So at the primary level, you don't want the disease to occur at all. Okay, at the secondary level, you are trying to identify disease very early so that while it is there, you don't want the person to start having manifestations that will be clear to you or clear to your physician looking at you. Then at the tertiary prevention, the disease is already there, but you just want to manage the situation a bit more, just to make that person a bit more comfortable. That way, you are trying to limit the spread. You are trying to limit the trauma. You are trying to limit the stress that will put on the body. So that's what we call tertiary prevention. So let's go on. Okay, so let's look at prevention of cervical cancer, which is the one we've heard so much about, which is the one that's quite common, and most interestingly, which is the one that is reasonably vaccine preventable. Okay, so cervical cancer is mostly caused by a virus called human papillomavirus. Some people may not have heard that cancers can actually be caused by viruses. So let's get it home today that that's a virus called human papillomavirus, and that's actually the commonest culprit in cervical cancer. There are other reasons, like risk factors, including smoking, HIV infection, having multiple sexual partners, and using hormonal contraceptives, especially combined contraceptives, for more than 5 years. So if we're going to talk about primary prevention of this cancer, we're going to be looking at what are those things we do that could, expose someone to have cervical cancer. So lifestyle is very, very essential in trying to do a primary prevention of cervical cancer. So if you look at the risk factors above, like HIV infection, multiple sexual partners and smoking, these are modifiable risk factors. By modifiable, I mean something you can do something about. The ball is on your court. And you can actually tell yourself, I'm going to live a healthy lifestyle, have safe sex, safe sex, and safer sex, using barrier method where necessary, keeping to one partner as much as possible, avoiding smoking, and then judicious use of oral contraceptive. So when you want to use oral contraceptive, it's good to have interaction with your OBGYN doctor, your gynae doctor, so that you are sure that you're actually using it properly. That way, you could actually, reasonably avoid cervical cancer. But again, the highlight of this discussion today will be that cervical cancer is vaccine preventable. Just like you have polio, just like you have so many diseases that can actually get a vaccine for, yellow fever, and all of that, you can actually get a vaccine. Hello, can you hear me? Sorry, hello, can you hear me?
Yes, we can hear you now.
Fine, so let me just move a bit faster. So we have vaccines that can actually help us to, as a secondary way of preventing cervical cancer. We can use what we call Gardasil 9, which is what is most common in the United States today. Prior to this time, we had Gardasil 4 and Cervarix. So Gardasil 4 and Cervarix are reasonably available in Nigeria, but Gardasil 9 is not readily available in Nigeria. You have Gardasil 9 as the main vaccine used against HPV in the United States. I must tell you that using this vaccine actually also goes a long way in preventing what we call warts. Warts are actually tiny growths that can occur on the vulva, on the vagina, and around the anus. So using this vaccine can actually also reasonably prevent vulvar cancer, can actually also reasonably prevent anorectal cancers too. So that's that. But to be able to make it more effective, that's what we call screening, to be able to detect this cervical cancer very, very early in the stage. So at the point where it has not yet become a cancer, one can do what's called a pap smear. Pap smear, the host will probably be able to explain much later, because that's our own area of specialty too. Being able to take some sample from the cervix and look at it under the microscope and look at the kind of cells that are there. to be able to tell, oh, we have what looks like a pre-cancer. So we do screening by either doing a pap smear or doing what's called a co-testing. Co-testing. One can do it together with doing HPV testing. You're going to see it in the next slide when we go to the next slide. So these are the primary, secondary preventive modes you have for cervical cancer. But sometimes this cancer occurs, and unfortunately, because pap smear is not easily taken up in Nigeria and Africa, a lot of women come with the cancer already in existence. And therefore, when they come, we try to do a couple of things to try and reduce the spread of this cancer and actually prolong the life of the woman. That is where surgery comes in, like removing the entire womb and removing the ovaries, and then using special radiation to be able to burn out the cancer cells. And also use special drugs or chemotherapy to be able to limit the spread of the cancer. Next slide, please. So in the next slide, we're going to be looking at the pattern of how the testing can be done. I mean, the routine screening that a woman should go through. There are routine screenings that could be done today, and they are readily available everywhere in the country. I must say, at least most states in the country should have availability of screening for cervical cancer. You don't want to start screening somebody who is less than 21 years. A female who is less than 21 years may not need to be screened. But someone who is between 21 to 29 years can actually be screened. Let me say here that from 21 years to 65 years, everyone should go for screening until you are told that you are no more eligible for that screening. 21 to 65. Instead of 21 to 65, you have people who are 21 to 29 who can do pap smear every 3 years. So if you do pap smear once every 3 years, by the third pap smear, if one is told that there's nothing wrong at all, no abnormal cell has been seen in the test so far, that person may actually be asked to stop. But for people 30 years to 65 years, we prefer what we call co-testing. It's not contesting, it's actually co-testing. What I have there is co-testing, like I said it earlier. So here you have maybe HPV testing together with doing the pap smear, and that can be done every 5 years. If it's not comfortable for that person can also do pap smear alone for every 3 years, just like you have for people who are between 21 and 29 years. Okay, so for people that are more than 65 years, no screening is recommended if they have been screened initially before this time and they've not had any issues. Or they have been screened 3 times and they're negative, and then their lifestyle is not actually endangering them to having cancer. So above 65 years, someone who has a healthy lifestyle, safe sex, is not likely to continue screening. I think that the previous screens are fine. Next slide. So now we're going to be looking at the prevention of another kind of cancer called ovarian cancer, which, by the way, is becoming quite common in our environment now. In the center where I live, ovarian cancer is one of the cancers that is commonly in presentation in the Nnamdi University Teaching Hospital right now. And quite unfortunately, just unlike in cervical cancer, ovarian cancer does not have any successful screening method as yet. As we speak right now, globally, there's no clear-cut acceptable way to say we are screening for ovarian cancer. A lot of things have been tried, but it actually makes a lot of brick wall at the end of the day. Unfortunately, also, too, there's no vaccine that can lead to prevention of ovarian cancer just the way you have for cervical cancer. But I can tell you that a lot of research is ongoing to see whether we can get, some sort of screening method to be able to detect the disease very early. However, the prevention can also be targeted at the risk factors. Therefore, we can also reasonably talk of primary prevention of ovarian cancers. Do not mind me, I'm talking too much. Ordinarily, I mean, that's the way it is. I ordinarily would want to talk and get feedback and ask you if they're hearing me. I hope someone is hearing me, please.
Yes, please, we can hear you clearly, sir.
All right, so prevention of ovarian cancer primarily can be targeted at the few risk factors that we know, or some risk factors that we know. Okay, so family history is one of those risk factors. Family history, genetic factors, and by family history, I mean if there's a first-degree relative, mother, daughter, sister, brother or father who has had history of breast cancer, colorectal cancer. Colorectal cancer, by the way, is actually cancer of the intestine, all right? And then ovarian cancer. So men can have breast cancer and men can also have colorectal cancer. But it's only women that can have ovarian cancer for obvious reasons. So if there's any family member who has had first-degree relative who has had breast cancer, ovarian cancer, or intestinal cancer, it calls for the other family members to actually, be on the lookout and probably do what we call genetic testing. One of those things that could be tested is what we call BRCA genes. BRCA1, BRCA2, but BRCA1 is actually one of the most important things to test, in this case. So, but like I said, because it's a bit difficult to do the primary screening, primary prevention, secondary prevention is a bit difficult. So most times in Africa, even globally, most of the patients who present with ovarian cancer come actually quite late. It's huge as more than 75% of the diagnosis is made late. So the target is mostly at tertiary prevention. So if a woman feels unusual discomfort, bloating in her abdomen, and a lot of indigestion and loss of appetite, anorexia, mostly for postmenopausal women, women who have gone beyond their beyond seeing their period, then that person should actually come and ask questions. Sometimes don't just understand how you are feeling in your tummy. That feeling you don't understand in your tummy, if you are 50 years of age, 60 years and above, please come and describe to your OBGYN doctor exactly how you're feeling. That could just be early stages of ovarian cancer. So if you come early, drugs can be given, what we call chemotherapy. Surgery can be done. That way we remove the ovary and remove the womb. That's called total abdominal hysterectomy and bilateral pharyngophorectomy. You can also do radiotherapy by using special lights of radiation to be able to burn out the cancer cells. So our advice that appropriate health-seeking behavior is very important, and people should be able to present their symptoms very early. Another cancer is the cancer of the womb, which is the last I'm going to take today for the sake of time. It's becoming common to have cancer of the uterus. Quite common. And you can see the risk factors here are things you can actually work on. The common risk factor here is obesity, diabetes, metabolic syndrome. By that I mean someone who has high lipid, high cholesterol, and is obese and is hypertensive. That's what I mean by metabolic syndrome. Then someone in the family has also had history of breast, ovary, or cancer of the intestine. People who have polycystic ovary syndrome, and people who use oral contraceptives, especially estrogen-only contraceptives, and people for one reason or the other, maybe for treatment of breast cancer or for any other reason, are using tamoxifen for more than 5 years. And then, pretty unfortunately, for women who have not been able to have children, throughout their life, they're actually, unfortunately, at risk of having cancer of the uterus. So you can see that exercise is very important here. For one to be able to avoid obesity and diabetes, exercise, healthy diet, and optimal weight, keeping good weight is actually very good. Then judicious use of hormonal pills. Unfortunately, we're in a country where people access a lot of medications without prescription. So every medication in Nigeria, literally every medication is OTC, but over the counter. That's not supposed to be so. So please do not just go to the chemist shop or to any pharmaceutical shop and say, give me oral contraceptive on your own. That should actually be done by a doctor. Like I said, there's no screening yet. It's quite disappointing yet that there's no screening method to be able to detect cancer of the womb very early. Smoking has a preventable role. A lot of researchers think that smoking can actually help to prevent cancer of the uterus. But you and I know that does not mean we're going to start smoking. Because when one smokes, you're exposed to so many other cancers, like cancer of the lung, like cancer of the cervix, like we saw earlier. And indeed, most of the cancers on earth actually are related to smoking. So while we are saying that smoking could be preventive, it doesn't mean that one should actually just go and start smoking. So remember to present very early, especially if you are gone beyond the age of menopause. A woman who is not seeing her period anymore should actually present early, especially if there is bleeding vaginally. Any woman that has stopped seeing her period, once she notices any vaginal bleeding, must please present to her OBGYN doctor. That's actually the take home today for cancer of the womb. So in conclusion, I want to say cervical cancer is the leading cause of cancer deaths in Africa, yet it is preventable. In the United States, there's hardly availability of cancer of the cervix now, except sometimes in people who have HIV disease and some of those conditions. But in Africa, it is the leading cause of cancer deaths, genital cancer deaths in Africa. It is vaccine preventable, and we have Gardasil 9, Gardasil 4, Sevarics to be able to prevent. That's the panacea for preventing cervical cancer. Unfortunately, ovarian and endometrial cancers are becoming common, and there's no screening method available for them to be detected early enough. However, keeping healthy lifestyle and presenting very early to your OBGYN doctor is going to go a long way in helping prevent these cancers or limit the damage it can cause. So proper health-seeking behavior is actually very key and essential. I want to thank you all very much for your attention. I'll be available for question and answer later on in this discussion. Thank you very much.
Thank you so much, sir, for that session. I believe we have jotted down our questions so that we don't forget them. So once we move to question and answer session, please feel free to ask Dr. Tobichi your questions. Thank you so much. We are very grateful for that. Very quickly right now, we are moving to the second speaker. Our second speaker is Dr. Chikadibia Ukoma. Dr. Ukoma will be, Dr. Ukoma is a consultant hematologist from Federal Medical Center, Kefi, and he's the founder and the executive director of Leukemia Care Plus initiative. And this morning, Dr. Ukoma will be telling us about hematological cancers. Hematological cancers, that is cancers of the blood. All right, so like I said earlier as well, please get ready, jot down your questions so that you don't forget them. So we welcome you to the floor, Dr. Ukoma. Let's believe you're here. Is Dr. Ukoma here? Let me check.
Hello, ma. Have you admitted all those in the waiting room?
Yes, I've clicked on admit all, so they are joining.
Okay, he's here. He just needs to mute. He's still muted. Please unmute, Chief.
Okay, let me do that now. Dr. Ukoma.
He's here to unmute. I don't know if I can reach him on phone. Dr. Odukoya is already waiting. I don't know.
Please, can you unmute Dr. Ukoma?
Okay. Dr. Odukoya, I don't know if he'll be at a function, but we join us. I need to call him on phone.
Okay, should we have Dr. Odukoya now, since he's here?
Yeah, if he can, if he's ready.
Dr. Odukoya, do you mind?
If he isn't ready, I can take my
now?
Yeah,
session,
it's fine. It's fine. I can go now. Can you hear me?
All right.
Okay. Thank you, sir. We
so
can.
much. All right, so right now we'll be having Dr. Odukoya Lateef. He's a pathologist and he will be telling us about gastrointestinal cancers. That is the cancer of the intestines. All right, so we have Dr. Abdulateef Odukoya with us. You're welcome. Thank you so much for joining us, and thank you so much for admitting to share your knowledge with us. You have the floor, sir.
All right. Thank you. Can you hear me?
Yes, sir.
Yes. So good evening, everyone. So I'll be discussing about gastrointestinal cancers. Generally, gastrointestinal cancers will mean cancers that affect the digestive system. Majorly, we will believe that that starts from the mouth, the esophagus, the stomach, the small intestine, and the large intestine, as can be seen in the picture on the slide. So these are cancers that affect this part of the body, the esophagus, the stomach, the colon, which is the large bowel, and then the small intestine, the rectum, and also the anus. So I'll majorly be concentrating on stomach cancers and colorectal cancers, which are the cancers that affect the large intestine, because those are the commonest part of the gastrointestinal system that is affected by cancers. So, and I'll start with the colorectal cancers, which are the worldwide. These cancers are the fourth commonest cancers affecting human beings globally. And as previously discussed by the first speaker, these cancers have ways that some of them can be prevented from occurring. Some can be picked up at the early stage so that they don't cause devastating debilitations to people. And then there are those that, if they are treated early, then they can prevent mortality for the affected individuals. So cancers are generally difficult to treat, and so it is better to prevent them. And it is also important to say that nothing 100% prevents cancer. In fact, one of the textbooks that we use tells us that the only way to prevent not having any risk of having cancers at all is not to be born. So once you are born to this world, there is actually a risk that you have cancer. And some of those risks are due to the factors that are genetic, inherited from our parents, you understand? And then other factors that can be avoided are also environmental factors, lifestyle factors, are also factors that can make us to prevent cancer. But nevertheless, we still try to prevent these cancers, even though we know that the risk still exists. So, so colorectal cancers. So here are some of the risk factors that have been discussed and found to increase the risk of people getting colorectal cancer based on research that have been performed all over the world. So the first thing is being physically active has been found to have increasing and convincing evidence of preventing colorectal cancers. And in fact, not only colorectal cancers, even breast cancers have been found to be reduced in those that are physically active, that don't have sedentary lifestyle. Then the second factor is consumption of whole grains and food rich in dietary fibers. So it has been found that the food
and put us inside.
Please, moderator, can you tell people to mute?
Yes, please mute the mic.
Dr. Dukaya, please unmute. Dr. Dukaya, please unmute.
All right. Can you hear me now?
I'm going to be intermittently muting all. So once I do that, please just unmute and continue, please.
Okay. I didn't notice that. Okay, so the second factor is it has been found that consumption of whole grains and food rich in dietary fibers is also one of the modifiable life risk factors that people can do. So what we eat has a great deal in affecting our lives, the kind of diseases that we come down with. And this is so also with cancer of the colon or cancer of the large intestine. It has been found that if people consume diets that provides at least 30 grams of fibers per day, that means foods that are fruits, vegetables, starchy food that are natural, also helps to prevent people from developing colorectal cancer. Another one is consumption of the dairy products. So consumption of milk, cheese, also are things that have been found from studies to reduce the risk of people having colorectal cancers. And there are scientific basis for this risk reduction in people that are beyond this discussion. So it's been found that when people consume a lot of dairy products, that is milk, cheese with their meals every day, it also reduces the risk of developing colorectal cancer. And the fourth one also is colorectal cancer screening is one way that also helps to prevent colorectal cancer. And this screening is important because it's been found that one of the major risk factors for all cancers, and in fact, many of the non-communicable diseases, is growing old. So as people grow old, their risk of having cancers increase. So one of the things we want to do is, okay, before those cancers develop in people as they grow old, we want to pick it up, the things that can predispose to those cancers, we want to pick it up and be able to offer treatment for them so that they don't come down with the cancer itself that then kills people that could have still lived longer than the time they develop the cancer. So this screening is recommended for people between the age of 45 to 75 because it's now been found that a lot of young people even come out with this cancer, even people in their 40s. So we want to start screening people from the age of 45. And there are simple tests that are available for this screening to be done that you can easily speak with your doctors and they can order the test for you in the laboratory. Some of the tests are as cheap as I think 5,000 or 3,000. And these tests can be done every once in a year, once people become 45 years, especially when there's a family history of colorectal cancer or even other cancers like prostate cancer and even breast cancers in your family or ovarian cancer, any cancer at all. You can take it upon yourself to start screening yourself every year or every 3 years by doing these tests that are easily available and accessible in the laboratories. So the other test that can also be done is there's a test that is called colonoscopy. So colonoscopy is that they use something that looks like a video to look into the intestine to see if there's any lesion there. There are some lesions that are called polyps. These polyps are actually like precursors to cancers in many people. So when they pick up these polyps by looking into your intestine, they can take them out and look at them in the lab and see if they have cancers in them. If they don't have cancers in them, then it means that you have to be followed up closely to make sure that you don't develop cancer. So this colonoscopy in people who have polyps or family history of polyps can be done every 5 years to 10 years. So maybe someone's father died of colorectal cancer or their brother died of colorectal cancer. Those people can go for this colonoscopy every 5 years just to screen them from prevent them from developing colorectal cancers. So the next slide, please. The next slide, that's the third slide or the fourth slide.
Is it?
The fourth slide, the fourth slide.
And then this is the next slide.
The fourth. Yes, so these are factors that increases the risk. The factors I talked about the first time are factors that reduce your risk. Those are the things you do to reduce your risk. Now, what are the factors that increase risk? Factors that increase risk of colorectal cancer, the first one is consumption of red meat. There are people who consume a lot of meat, beef every day. Beef every day is also one of the things that have been found to be convincingly increase the risk of colorectal cancer. And in fact, other cancers, breast cancers also, you understand? So it's been found that just taking red meat can increase risk of colorectal cancer. Excessive consumption of red meat, pork, beef, lamb, mutton, goat meat. Some people don't like fish at all. They just continue taking meat. So it's been found that limiting consumption of red meat to not more than 350 to 500 grams per week is one of those things that can prevent people from developing colorectal cancer. Like we said, it doesn't mean that this 100% because there are other factors like genetic factors, you understand? But reducing consumption of red meat can actually reduce risk of developing colorectal cancer and even other cancers. The second thing that can increase risk is consumption of processed meat. And in fact, not only processed meat, processed food generally. So some people don't like to take any natural food. Everything must be canned, tinned, must be bought from the restaurant, must be bought from the supermarket, where most of them have been overly processed. You understand? So we should try our best to always go for natural, not seriously processed meals. You understand? Every day, meals that have been sorted, fermented, smoked, Some people, they just like smoked stuff, suya every time. Some people fried every time. We should just try and avoid all that, because these also prevent us from developing other diseases, because even cardiovascular diseases like hypertension are also these are also some of the risk factors for those other diseases, not only cancer. So it is better to consume very little processed meat, better to avoid it if you can, and go for natural meats. And even then, when you go for the natural one, that's the one that the red meat that you buy in the market that have not been processed, then even those, you have to limit your consumption of those. The third factor that can increase our risk is consumption of alcoholic drinks. Consumption of alcoholic drinks, all types of alcohol, strongly predisposes to colorectal cancer. And in fact, not only colorectal cancer, even breast cancer is also predisposes to that. And even other diseases like hypertension, cardiovascular diseases, it also predisposes to that. So for cancer prevention, it is recommended by international organizations that the best thing is actually not to consume alcohol. But because people love to consume alcohol, then they give other suggestions of, okay, if you do consume, then do not exceed greater than 20 grams per day for men, and not exceed greater than 14 grams per day for women. So those are some of the things we must do to reduce the risk of developing colorectal cancer. And the last one that also increases the risk is overweight or obesity. Overweight or obesity. So people gaining weight can also predispose to colorectal cancer. And in fact, not only colorectal cancer, I always like to say that even breast cancer, even ovarian cancer, like the first presenter said, and other diseases too, cardiovascular diseases, hypertension, diabetes, these are also risk factors for all those things. So when we try and do some of these things, we are not only even preventing ourselves from getting cancers, but we're also preventing ourselves from getting other diseases and living a better and more healthy lives. So avoid weight gain, keep your weight as low as possible throughout your life. So some of these things need to be deliberate. It's not like we're not saying that people should starve themselves. No, as you can see, the recommendations are not saying you should not eat. They're saying that you should vary what you eat and make sure they are healthy and not over-consume some things. So these things needs to be deliberate. And when you speak with people who do some of these things, who do exercise from time to time, who watch what they eat, and if you speak with them, you will actually realize that some of them seem to have a more healthy life. So next slide. So in the next slide, I would just say at least a few things about stomach cancers. Stomach cancers are cancers that affect the stomach. Moderator, please.
Hey, on mute when I mute you. You can unmute, sir.
Okay, so stomach cancers are cancers that affect the stomach, and like I said, all the risk factors that increases colorectal cancers and risk factors that reduce colorectal cancer also are some of the factors that reduce the risk of developing stomach cancers and most other cancers. So only a few ones that were not talked about for under the colorectal cancers I will mention here. So one of the major risk factors for gastric cancer, which is stomach cancer, is increased consumption of salted or overly or highly spiced foods. So people that like too much salted foods, you understand, overspiced foods. Those are some of the risk factors for developing stomach cancer. And not only stomach cancer, even nasopharyngeal cancer and esophageal cancer. These are some of the risk factors for that too. Then there's an organism that is called Helicobacter pylori organism. This organism is a major cause of gastric ulcer, what we call ulcer. Every day we all say somebody has ulcer. People think that it's because people don't eat on time or people don't eat well that they get ulcer. No, about 50% of the world population have this infection. It's not like it's not infection that maybe causes serious sickness that people get admitted in the hospital. It just gets in people's stomach, and then over time predispose them to developing ulcers in their stomach. And it's been found that this infection can eventually lead to development of stomach ulcers in this patient. Then the other risk factors that I've mentioned for colorectal cancer also apply for gastric cancer. So how do we prevent this? Reduce or avoid intake of highly salted foods. So if we can do that, just like we would do for other factors that I've mentioned, then we'll reduce the risk of developing stomach cancers. Another risk factor for stomach cancer is smoking. And smoking is not only a risk factor for stomach cancer, it's perhaps a risk factor for almost all the cancers. Like 30% of cancers are believed to be associated with smoking history. So if people can avoid smoking, then it can reduce their risk of developing not only stomach cancer, but many of the other cancers. Then screening for H. pylori infection. Screening for H. pylori infection can also prevent people from developing this cancer. If you get screened and they find that you have this infection, it can be treated. It can be treated, completely treated in patients who have it, so that when you get treated, then the risk of developing stomach cancer is avoided. So the tests are available. You can go for screening. If you think you have ulcer, like people say, you eat on time. Eating on time is not what will cure it. You can eat on time and still have this infection, and then even still have ulcer and still have a risk of cancer. So the best thing is to speak to your doctors. They screen you for the infection. If you have it, you get treated, and then that way you are able to reduce the risk of cancer. So one of the other things that I will talk about, the last slide now, that I'll quickly talk about is one of the ways to prevent this cancer is actually to detect them early. And how do you detect them early? It is by people speaking about their symptoms that they feel to their doctors. So what are some of the symptoms that people can feel that can easily make them to speak to their doctors, and then these cancers can be picked up? So for colorectal cancer, like I said, early detection allows early intervention, promote good outcome, and could prevent death in these patients. So if you have blood in your stool, or your stool is blood stained, you went to the toilet today, you saw blood, you went tomorrow, you saw blood, next tomorrow you saw blood, please, you need to speak with your doctor. It doesn't mean that you have colorectal cancer. It could be an early symptoms of an early disease that if they pick it up now, you would be treated and you will be fine. It could even be something else, because it's not only cancer that causes blood in the stool. And you still need to be treated for all those. Even parasites can cause blood in the stool. So you need to sometimes intentionally examine your feces when you go to the toilet. Another thing is change in bowel movement. You have diarrhea today, constipation tomorrow, diarrhea today, constipation tomorrow, diarrhea today, constipation tomorrow. Please speak to your doctor. Maybe a sign of something going on in your intestine. And if it's picked up early, you would get treated and you would be fine. Then people may have stomach pain that does not go away. Maybe a sign of an ulcer, or it could be a sign of an early disease, a cancer that if you picked up early, you will be treated. Aches in the stomach, bloating, cramping in the abdomen, you understand, swelling of the abdomen, you need to speak with your doctor. If people have unexplained weight loss, you're losing weight that you cannot explain. You think it's because you're not eating well, but you feel you're eating well, but you're still losing weight. Please, you need to speak with your doctor. This could even be a sign of any other cancer, not only colorectal cancer or stomach cancer. So these are some of the symptoms, few symptoms. There are others that specifically speak to gastrointestinal cancers. And if people have any of them, or feel that they have any of them, they should speak with their doctors so that these things can be picked up early. Thank you very much for listening. Moderator, I am done.
Thank you so much, sir, for that session. We are most grateful. Please, like I said, I have jotted down a number of questions. Please let's write down our questions so that when it's time for questions, we don't forget them. So right now we are moving to exercise break.
Excuse me, ma.
Yes, bye.
Sorry, please. The CEO of Bay Fitness has been waiting for more than 30 minutes now. Please, let's quickly take him because he actually had to stop a lot of things to join us today. Just 5 minutes of exercise break, and then Dr. Chikadibia will take over from there. Please, thank you, ma'am.
Yes, thank you so much, Dr. Ada. So we are calling up exercise instructor, Bay Fitness. If you listen, guys, you realize that the two doctors that have spoken to us spoke about exercise, and now we are going to have a session. So please, let's get ready for him. Please, you have the floor. Thank you.
Hello, everyone.
Good evening.
Can we all hear me or see me?
Yes, we can.
Go ahead. We are ready. We are standing already, some of us.
Okay, you can. Oh, okay, good. Okay, so now, basically, I need to just something. I could do this for 2 hours, but I need a draft from you. Coordinator, I'm asking.
I didn't get that. Sorry.
How many minutes? How many minutes?
Okay, you have 5 minutes. You have 5 minutes, sir.
That's my.
Yes, you have 5 minutes. Yes,
okay.
sir.
Okay, so now, just going to show something within 3 minutes up to 10 things. And explain certain things to you. So now, when you are morning, you stretch. So your stick is something like this. Take your hands above your head.
Can we all be on our feet and try this out, please?
Yes. Above your head like this. And hold your wrist and push it very well. From the side, above
We are all doing it too.
Right hand and left leg back. Your right hand up, your left leg back, and come back a little bit. 1, 2, 3, 4, and 5. Take it to the other side. Your left hand up, left leg. 1, 2, 3, 4, and 5. Close your leg together. Close your leg together. And come down. You hold your cap. You hold your cap and take it down. 1, 2, 3, 4, 5, 6, 7, 8, 9, and 10. So what I'm about to show you. Hello?
We can see you, sir.
Okay. I can see that it's hanging. So what I'm about to show you, you can use it 5 minutes exercise. Running at the spot. Can you hear me? Can you see me? Can you see what I'm doing?
It looks
Can you
like
see what I'm doing?
you are bent
Can you see
downward.
Can you see what I'm doing? I'm
Yes.
running at the spot. Like this.
Okay.
I think my phone
Dr.
is
If
hanging.
you mute your mic, we'll see him.
Say that again, please.
If the moderator mutes her mic for a few minutes, we'll see you.
Okay, you see me, right? Can you see me running at a spot? I'm running at a spot. I'm not just doing that. I'm running at a spot like this. Can you all see me? Can you see what I'm doing? Can you see what I'm doing? Yes. Can you see what I'm doing? This alone, for a beginner, this alone is fantastic. Do this for like 60 seconds. Do this for like 60 seconds. And do a beginner's jumping jack like this. Beginners jumping
I
jack.
actually can't see what you're doing. You're bent downwards. I don't know if you can just explain verbally.
No. I'm not bending down. I'm not bending down. I'm hard. I think it's hanging. I need to relog in.
It's
I
hanging,
think
actually.
oh, it's hanging. I've done a lot of things, not just bending down. I'm not just no.
Is your video still on, sir?
Yes, my video is still on. I'm not just bending down. Let me log in from your. Can you log in from Didi's phone? Can you send the link to Didi? Let me log in from
Don't
our
worry,
phone.
we're almost done. The time is almost up. Don't worry.
Okay, running at a spot. What I was doing is running at a spot. I was running at a spot. Thank you, Dr. Ada. That's running at a spot. That's what I was doing. I was running at a spot. 2, 3, 4. Can everybody join her what she's doing? That's what I was doing. 5, 6, 7, 8, 9, and 10. Okay. Beginners jumping jack, you separate your leg one by one and take your hands above your head. Separate your leg one by one. Yes. And bring it back. 1, 2, 3. Yes, like that. Thank you, Dr. Ada. No, don't do that. Don't jump. Just okay. 4, 5, 6, 7, 8, 9, and 10. You come back to running at the spot. That's enough. I think, Dr. Ada, you need to go work with my time. 5 minutes is not enough for this exercise. And meanwhile, I don't know why I'm bending. I don't know why I'm bending down while I'm still standing here. So, thank you so much.
Yes, thank you so much, sir.
Thank you so much, sir.
You have me here. I'm grateful. Thank you.
Thank you. Woo, I believe some of us did that. If not,
see you next time.
It's not good to be seated for so long. An exercise, as we have been told, is very important as a preventive measure for cancer, as well as many other diseases. So thank you so much, Bay Fitness. We'll look at possibilities of extending your time some other time. Thank you so much. So very quickly, Dr. Okoma is here. I don't know if he can have the floor now. Dr. Okoma is going to talk to us about hematological cancer. I saw him, I believe he's still here. Please, you can unmute and you have just 5 minutes, so you can unmute and have the floor. So that immediately after his session, we move into question and answer. You have the floor, sir, Dr. Okoma. Let me share your screen.
Yeah. Thank you very much. I want to thank Dr. Fatis for this wonderful opportunity. I also commend you for what you are doing. We're talking about hematological malignancy, preventing of hematological malignancy. And if we can go to the next slide. Hope you can hear me.
Perfect.
Yes, sir, we can hear you, sir.
Okay, because I'm in a car, so okay. Well, hematological is also blood cancer. They're called blood cancer. That's the layman language for them. Hematology is blood related. So when you talk about hematological malignancy, you're talking about blood cancers. And there are primary cancers of the blood or blood forming organs, which are the bone marrow and lymphoid tissues. There are a group of disorders, because when you talk about blood cancer, blood is not just one entity, it's an organ and made up of different, it's a tissue made up of different organs and different cells. It's a group of disorders that affect any of the 3 cell lines of the bone marrow or the immune system, which are the red blood cells, the white blood cells, platelets. Okay, they affect both male and female, young and old. But you even have those that are congenital. Some babies are born with leukemia, and that's what we're talking about. The next slide. Okay. Now, just type of malignant blood cancer. Those are affect for those results from the bone marrow. You have leukemia, and when you talk about leukemia, you have acute lymphoid leukemia or acute myeloid leukemia. These are very aggressive diseases that, if not left untreated, could lead to death within 3 months. And then you have the chronic leukemia, which could be myeloid leukemia, chronic myeloid leukemia, could be called CML, or chronic lymphocytic leukemia. CLL. These ones are actually very, very indolent, and people can be living with them without even knowing for years. So cases like chronic leukemia are even found on just on when you go for routine medical checks, like for your interview and that's you for blood counts, and then you discover a person has leukemia. Then you have what we call the myeloproliferative disorders, which could include what we call the red blood cells, the polycythemia rura vera, when we talk about the platelets, we have essential thrombocytosis. Those ones are myeloproliferative. And then we talk about the plasma cell dyscrasias, which include the multiple myeloma, known as multiple myeloma. And then there is one which actually we call a pre-malignant condition, which are called myelodysplastic syndrome. Then in lymphoid organ, those that originate from the lymphoid organ, you have lymphomas, which could be Hodgkin lymphoma and non-Hodgkin lymphoma. Now, what makes a medical malignant very peculiar, unlike the other two presenters which you have there before, most cancers are still with tumors. Tumors are swelling, massive. But in blood cancers, you don't see any mass, you don't see any swelling. And that's why most people don't even believe there's something called blood cancer, because you may be living with it without knowing that you have leukemia or blood cancer ongoing. So it's important to know that these are actually entities that are. Can we go to the next slide? The next slide. Next slide, please. Okay, thank you. Now, I'll use this photograph to actually describe what happens. What you are seeing on your left side is a bone. That's the long bone of the leg. And within them is what we call the bone marrow. And that's what is in that sketch. You can see there. And that's where blood is being formed. All the blood, like I said before, the blood has three parts: the red blood cell, the white blood cell, and the platelet. The red blood cell is actually meant to carry oxygen. That will give us strength and energy to do the work which we do. And both to your brain and to the other vital organs. The red blood cell carry oxygen to those vital organs. And when they are low, you have what we call anemia. And then the second group of blood cells are what we call the white blood cells. Those ones are defenders of the body, they are soldiers of the body, they defend us against infection, both bacterium, viral, or parasitic infections. And then the last cells are the platelets, which protect us from bleeds. When you have a cut in your blood vessel to prevent blood from blood loss, those platelets tend to line up the cells. Now, what happened is that the bone marrow, those are the first cells which is called the hemopoietic stem cell. And that's what continue to divide to give us the when you go to the extreme right, those are the actual cells. Unfortunately, I don't have a pointer here, but I believe the cells which you are seeing, the red one, those are called red blood cells. And then you have the platelets, those tiny, tiny ones. And then you have the white blood cells, and then on top, above them, you call the lymphoid cells. So cancer can occur at any point at this in these stages of maturation. If there's any damage occurs to these cells, it will arrest the maturation of the cell, and then that is the kind of blood cancer you will see. Hemopoietic stem cells, and we divide to have the common what's called mononucleoid validation cells, then the common lymphoid progenitor cells. And then that myeloid progenitor cell can divide to give us what's called the platelet, monokaryocyte, which then gives platelets, and then it cannot divide again to produce white red blood cells called erythrocytes. That red blood cell is called erythrocyte. And then what then can also divide to give us a called myeloblasts. And the myeloblasts actually produce the white blood cells that we're talking about. So if there's any arrest in any of these parts of maturation, this is what we call the leukemia. And then on the extreme left, you have the lymphoid progenitor cell. This one divides to give us the lymphocytes. The lymphocytes actually help us prevent viral infections damage in the genetic makeup of these cells, that's what you do to have leukemia happening. Or if you have multiple myeloma happening with the way that is damage to the lymphoid cells. You can see the last cell that is called plasma cell. Plasma cell is what we have in multiple myeloma. Plasma cell produces immune cells that tend to defend us against the infections. And when you produce in excess, you tend to have what we call multiple myeloma. Next slide, please. What causes you know that point in their maturation, because it starts from the one end to the other end. In that can lead to block formation. But we don't know what really caused them, but there are factors that you need to see with them to leukemia and blood cancer. One of them is the cigarette smoking, which previous speakers also made related to. Cigarette smoking is almost every cancer you can think of. There's no cancer in the body that is not associated with cigarette smoking. So I still wonder what we are still smoking. And the next one is to high energy radiation. When you get exposed to high energy radiation, you lead to blood cancer. One of those high energy radiation is under high tension cable. That is not advised. Even near those high tension cables, people are even attributed from your phones, particularly when the current with the battery is so low. It rejects high energy radiation. Unfortunately, people physically about 3 phones on them about. They have exposure to chemicals such as like benzene or other industrial chemicals to make a plastic rubber a herbicide. Yeah, exposure to them can also lead to blood cancer. Viral infection like Epstein-Barr virus, HIV, human papilloma, human system leukemia virus. All these viruses has increased to having a blood cancer. Then also what you want inherited diseases which affect effective DNA repair. Have been found to have association to cancer formation. The next slide, please. The hand of this present, they're called the presentation which are missing prostate mass. You see muscle on the neck, on the armpit, or in the stomach, that abdomen. For most blood cancers like leukemia, multiple myeloma, you will never see any mass. What you will see is because of the excessive production of particular cancerous blood cells. For instance, leukemia is a blood cell. So when cancer develops, it now begin to multiply in excess in the bone marrow. And what that does is it now impedes on the bone marrow not to produce the other cells, like the red blood cell.
We are actually struggling to hear you, sir. Sorry, sir. I don't know if, I think it's your network or something.
Okay, I'm sorry about that. Okay.
Thank you.
Okay. Now, if what happens is if the leukemia is being produced in excess, it tends to impede on the bone marrow not to produce the other blood cells, like the red blood cell or platelets. And what happens is that you now have anemia. And that is going to be the presence of fatigue, weakness, and other signs of anemia. Then because the white blood cell that is being produced is also defective or may not be enough, you tend to have infections like fever, or with cheese and rigor. You can have frequent infection of the ear, chest infections like cough. You can have a person can lose weight. And then if the platelets is also affected, you may have what we call thrombocytopenia, that reduce amount of platelets. a person will start bleeding. It can bleed from the nose or any part of the body. Then one other thing that's associated with all blood cancer is bone pain. The blood cells are produced in bone marrow. And when the cells are multiplying in excess, or what they do is they cause pains in those bones. Particularly multiple myeloma is associated with low back pain, and can also be associated with increasing of pathological fracture. When a patient just gets up from the bed and then as they're about to stand up, we hear a snap and the leg breaks without any accident, without any fall. That's associated with multiple myeloma. And you can have organ enlargement, like the lymphoid organ will be enlarged, the liver might be enlarged, the spleen might be enlarged. So those are part of the symptoms you might see in blood cancer. Next slide. Yeah, this also like when you talk leukemia, you can see it affects almost every part, every system in the body. Okay, so that's how you can have a systemic infection where you have weight loss, you can have fever, you have frequent infections. Then you can have when you affect the lungs, you have shortness of breath. And they can affect the muscles when you have weakness. The bones are also affected when you have pains and tenderness, or when you touch, you feel pain when you touch the bone. Psychologically, very affected, there's loss of appetite and fatigue. Of course, the lymph node will be swollen. Of course, you have a spleen will be enlarged. You can also have the seedlings of the cancer cells into the subcutaneous tissue, where you have nodules. And you can also have bleeding into the skin, whether as purpura or petechia, or purplish patches in the body. So those ones are a sign of bleeding within or into the skin of the body. Next slide. So how do we prevent? How do we know what causes those things? Once you know what causes something, the next thing you need to avoid what causes those things. Then of course, you almost prevented having those conditions. But one thing which you also have to know is that, like I said, you will see any mass with leukemia or most of the blood cancers. And what they present with is just like fever and weakness and shortness of blood. And most patients tend to, what they do is going to treat for malaria and typhoid fever. We know we're in a malaria endemic area in Africa, and also typhoid is also rampant here. You see people treating for typhoid and malaria repeatedly without actually doing a full blood count to actually ascertain what's actually causing that fever. So it's advised that everybody should do at least twice every year, go for medical checkup. Do your full blood count. Full blood count is not too expensive. It's about 200 naira in some places, about 3,000 naira in some places. So do your full blood count. And once you notice that at least you're having anemia and your white cell count is shooting, is hitting the roof, then ask to see a hematologist. It's very common that most doctors, even in a rural area, do not even know much about blood cancers, and to keep treating for typhoid and malaria repeatedly. So please, it's advised that anybody who has been treated for malaria and typhoid, and then after 2 weeks you are down again, you should ask to be referred to see a hematologist where your blood cell can be analyzed with a full blood count and peripheral blood film. Okay. Then once again, it's as avoid smoking. Please, it's important we need to avoid smoking and all tobacco in all forms. Then there's need to have a lifestyle modification and behavioral changes. Okay, such as staying active, which what we just did now, is a very good exercise. It's advised you do that every day of the week. Be active with regular exercise. Eat well and healthy. That is very, very key. All this junk we eat in the name of food is not helpful, and it's hitting us negatively. You should love greens. Eat vegetables. Eat enough fruits. We have a lot of them in abundance in this country. So make sure you have enough greens in your food and enough vegetables on your table. Then I take antioxidants. If you're not a good person that take vegetables and fruits, you can get there are a lot of good antioxidants that tend to burn off these free radicals that tend to damage our cells and of course have to our immune system to prevent this cancer. Multivitamins are also good. I didn't talk more. This was my last slide. But I didn't talk much about treatment. Treatment is mainly by chemotherapy, but we have to diagnose first. Important is what you to actually prevent this condition. So I will stop here. If there are any questions, I've been want to elaborate more. Thank you very much.
Thank you so much, sir. We are grateful. Thank you so much for that talk. So very quickly now, please remember to write down your questions like I've always been reminding us. So very quickly now, I want to bring up the
Okay, ma, please permit me to share my screen. So she's also having network issues.
To tell us about value of. Can you hear me?
Yes, permit me to share my screen, okay? Thank you, sir. Thank you, sir. We hope that immediately after I'm done, we can take questions from the participants. I'm just going to do a 3-minute talk. The host is having issues with our network too. Okay, so ma, please let me share my screen.
Yes, I've permitted you. You can go ahead.
Perfect. All right. So it's just a very short presentation. Somebody was meant to take this, but she couldn't make it because of time zone and all that. So we'll put them down for another day. Okay. I'm taking value of prevention cervical cancer as a case in point because I will tell you a story. Sometime in I think 2009, I was in a meeting. Kindly mute participants. Wow, that's interesting. So please kindly mute the participants so that they can hear me. Sometime in 2009, I think during my youth service days, I was in this Medical Women Association meeting, and one of our leaders then said something about cervical cancer in Germany. Then I think I was working at National Hospital Abuja, and she said that presently in Abuja, in Germany, sorry, when she went for a program in Germany, they hardly see people coming down with invasive cancer. That is, let me make it simple, end stage of very bad cancer that is difficult to control. Remember, Dr. Tobechi talked about primary, secondary, and tertiary prevention. The emphasis on health hangouts with Dr. Ada is on primary prevention, and then secondary too. And I also want to announce that I'm happy to see that a lot of people actually voluntarily go for pap smears these days. It's one of the secondary preventive measures. So that is why I'm using cervical cancer as a case in point. So look at what is happening here. These are the common cancers in Nigeria. Why cervical cancer is the second most common amongst females? Look at this arrow here, the purple field. I don't know if you can see my arrow, my cursor here. So this arrow is showing us how much
we can't see
cervical cancer. You can't see my arrow. Can you see my screen?
Your screen is still stuck at value of cervical cancer prevention.
Oh no, what could have happened?
Yeah, it hasn't moved to the second screen.
Yeah,
to the second slide.
Yeah.
Okay, so okay. How about now, sir?
It's still the same.
Okay. Let me try sharing again because it's just visual. Difficult. Unfortunately, I don't even know how to navigate this. I think.
Wow. Does the moderator have the slides so that she can help you to share?
She has the slides, yes. Can you disable share, Dr. Ajikpe? Can you disable share for me?
Can I? Okay. All right. Okay.
Can you share from your end?
Okay, all right, let me do that. Do you want to permit me?
Yes, go ahead. Am I going to, okay, am I the host?
Yes.
Wow, that's serious.
Yes, you are.
Okay. Wow. This is a serious
Okay,
issue.
maybe you should continue. It's just that if we can see it, it will make more meaning,
Yes.
you know. Yeah.
Okay, well, I was just going to show some graphs. What I was trying to show us is the incidence of cervical cancer in Nigeria when you compare it to other developed countries, using USA as a case in point. While cervical cancer is still among the topmost causes of death in Nigeria, and among the topmost causes of death, especially in females, it affects females, not males. In the US, that's come so low, and other developed countries is even less than, it has gone below the 10th cause of the 10th most common cancers in developed countries. And part of what is happening is that they have been screening, they have been doing this primary and secondary prevention. And there was a second graph I was going to show you of how we have been experiencing a decline in cervical cancer in those parts of the world. And we're also expecting that from such meetings, we'll replicate that in Nigeria. Do we want women to die from cervical cancer? No. Are we going to do something about it? Yes. Part of what you're going to do about it is inviting your family members and friends to be part of what we are doing here. Let them join our WhatsApp group. It's easier for me to handle the WhatsApp group prior to this time, but as God will have it, we have a lot of volunteers coming up. We have a Facebook group. We have LinkedIn group now. We have 2 Instagram handles. We have Twitter, Telegram, and of course our 4 social media. 4 WhatsApp groups. So let them join up. They don't have to. The groups are very silent. We only open it up for communication a day before the meeting and shut it down few hours after. A lot of notable people are in that group. Okay, so we don't want it to be a group that is frequently loaded with messages, conversations that are useful and not. So share what we are doing. When we have the Zoom meetings, kindly share the Zoom link to let them join. Sorry for the issues we had today. As I said, we have a volunteer platform. We have grown. It was like a one-man show initially. I started this with my consultant at FMC1, Dr. Chukwebo, with my cousin, an engineer that usually joins us from France and moderates the meeting for us. And then at that time, we also had some of my friends who were calling up from different parts of the world to tell me that what we are doing is good and to give me suggestions on how to move forward. Recently, Dr. Jepe, thanks to her, I call her my prof. She's a doctor of physiotherapy and she's been the one moderating this meeting today. She actually called for volunteers, and currently we have a volunteer group aside our 4 WhatsApp groups, and we have 11 people volunteering there. Please permit me to use this opportunity to ask for more volunteers, because they are coming up means that we can go beyond WhatsApp, we can go and invade all social media platforms and make sure that the right information is available. Right after this, my talk, we're going to take the most important part of this session, and that is the Q&A session. Dr. Dukwaya is already on standby. Dr. Chikadiba is on standby. Dr. Njoko will join us soon. And it is part of the aim of Health Hangout with Dr. Ada. We want to bridge that gap. We want you to be able to ask your doctors the direct questions. Don't listen to all those people on the streets that are selling a gogo ishe, herbal medicine that can cure everything. You have the doctors on this platform. And for them to come, Dr. Dukwaya is joining us from US. You know, we had somebody from Canada and my friend from US who couldn't join today, but we told them that we're expecting them very soon, because we can't cover all breast cancers in 2 hours. All preventive measures for all types of cancer in 2 hours. So breast cancer isn't here, and prostate cancer is not here. Apology to the men. It was a very big oversight for me. But I can assure you, after this meeting, these things will be taken care of. Then, as per admitting participants into the room, before now we had it as an open room, but people had to sign in, type in the meeting link and then put in the passcode. But a lot of people who are joining us, we're not reaching out to only the professionals. We want this platform to actually reach those on the street. Do you get? So a number of them are not very competent in Zoom. Even me, I'm still learning on the job. So putting in that passcode made it more difficult for them to join. But somebody has said they should do something about it. put up a demo on how to use the passcode. And then from our next meeting, we won't need to admit anybody, to be open for all to join. Thanks for your understanding. So question and answer session can take up from here.
Thank you so much, Dr. Ada. So it's time for question and answer. The reason why it's called Hangouts is so that we can talk, you know. That's why, you know, when you hang out, when only one person is talking, it's not really. So please, let's ask our questions now. Our resource persons are still here with us. Please, when you're asking, just raise hands and I'm going to call. We have the next 10 minutes for this, and we believe this is the most important part of this meeting. So please go ahead and raise your hands. But let me go first, if I may. All right. My question is for Dr. Odukoya. I'm interested in knowing a little more about colorectal cancer, particularly for those with family history. Is there a particular age by which they should start? Because you mentioned colonoscopy that should be done every 5 years. Is there a particular age that they should start colonoscopy, or they can start as early as any age because of the family history?
Okay, yeah, thank you very much for your question. So, so what has been found is those who have, can you hear me?
Yes, sir.
Yes, so what has been found is those who have family history of colorectal cancer, those who have family history of polyps. There's a type of polyps that is called familial adenomatous polyposis. Means that these people have small growths in their intestine, and maybe a family member had it, or a family member like a father or mother or sister, that's first degree relatives, had colorectal cancer. So it's been found that family members of those people to have risk of cancers. So, and also recently, it's also been found that young people are beginning to have colorectal cancer. There is a popular actor that died of colorectal cancer. I think it was it 39 years old or something? I can't remember his age, or was it 40? So the recommendation now is that based on environment and accessibility, the first recommended screening is the fecal occult blood test. So that is that sometimes there is blood in the stool that you can't see with your naked eye. So for people who have family history of cancer, it is recommended that they start to do that kind of test every year, once a year, every year, from age of 45 years.
Okay, from 45 years.
Yes, from age of 45 years. So it's recommended they start to do it up until age of 75. After 75, it will not be based on your doctor's recommendation. Maybe you have other things, other symptoms, or other risk factors, then they can screen you. But from age of 45 years, what is recommended is, because there's blood in the stool that you can't see with your naked eye, and there may be an indication of something going on in the intestine, you should do fecal occult blood test every once in a year. Now, for people who have family members with familial, can you hear me? With familial adenomatous polyposis, those ones, it is colonoscopy that is recommended, and is recommended once every 5 to 10 years from age of 45 also. So those ones have people that have familial polyp in their family. So those ones you do colonoscopy every once 5 to 10 years from age of 45 until they are 75. So that way you can pick up something happening early in them. For us in Nigeria, the one that is most accessible is the fecal occult blood test. You can do it for as low as 3,000, I think, or 5,000. So those people can do that once in a year, every year, from age of 45 years.
Okay, so sir, you didn't mention abdominal ultrasound. It won't show anything, right?
Abdominal ultrasound is not, anything can be picked up in the abdomen that can be a swelling. So it's not specific for this case. So it is not a recommendation at all for screening for colorectal cancer. It's not one of the recommendations. because most of the time other swellings can obstruct your view in the abdomen that you, so you mean it's not specific. So it's not a recommendation.
Thank you, sir. I can see Joy Chooks. Please, you can unmute and ask your question.
Yeah.
Joy Chooks. Joy Chooks, your hand is raised. Others may go ahead to type their questions in the chat box. Joy Chooks.
Hello, good evening, everyone. Sorry.
Good evening, ma'am.
I wasn't close to my phone. I have a question on the directed to Dr. Njoku, who talked about the vaccination, the HPV vaccination. So I'm asking to know.
Chief, thank you.
Hello, people with me.
Sorry for the delay. Yes, thank you. We have this.
Hello.
Eh?
Hello.
No, not yet. Not yet. Are you available?
Hello.
Yes, we can hear you, ma. Can you go ahead, ma?
Okay. Okay. My question is, where can we access the HPV vaccination?
Okay. Dr. Tobechi.
Yes, I'm here.
Dr. Tobechi Njoku, yeah.
He's here.
I'm here. Okay. Okay, I'm here with you. I heard your question about accessing HPV vaccine. I don't know where you are. I don't know which state you are, but
I'm in FCT. I'm in Abuja.
Okay, fine. So if you're in the FCT, there's a chance that you're going to be able to have it from your local. In the other states, they have government house code room. It's either you have it domiciled in the government house or you have it domiciled in the Ministry of Health. So it depends on, in Imo State, for example, some of these vaccines are available at the level of the government house cold room, cold storage. There's a mega storage, cold storage, where for example, COVID vaccine comes to the government house from where it is now distributed to the PHCs, primary health centers. So if you are in Abuja, there's a chance that you could ask questions through the Ministry of Health. You could also ask in the National Hospital Abuja, and you could also ask through FDA, FCDA. You could actually find out from the region where you are. There could be regional distribution. I'm not sure, and I don't live in Abuja, but I can tell you that you could get it. It may come at a cost because unfortunately there's no national program per se on HPV vaccination. We only have a full-blown national program. But if you ask questions, we're going to be able to tell you. I can also ask questions and then get back to you through the host, Dr. Ada. Thank you. Over.
Okay, thank you. Because I'll be looking forward to that, or maybe I can also talk to Dr. Ada to get your contact so that we can make a follow-up. So because I have a group of friends, we also look at our health and some things we like to do it together. Some of them try to, join today, but thank God that Dr. Ada has said we can use the passcode other times. So they will also join. We're interested to have the vaccine and also do other things to take care of ourselves. Thank you.
Thank you, Ma. Any other question, please? You can also put in the chat room if you have a question, or raise your hand. Any question? Okay. All right, so if there are no other questions, we want to thank everyone. And then in rounding up, I think Dr. Ada has some announcements. I think she has taken it as part of, or you still have additional announcements?
No.
Okay. All right, so there is a little exercise that she has asked us to do in the chat room. We are looking at if you are interested in, we need a part 2 to cover prostate cancer and breast cancer. So maybe in the next 3 months. So she's asking that you type 2 if you are interested in that. So please, would like you to give us your response. All right, so we want to appreciate everyone, and our sincere appreciation goes to our resource persons. Some of them not even in Nigeria, and we are grateful for making our time to be here with us. We also want to sincerely thank all our participants. We are really grateful for making this time with us. Without you, like Dr. Ada said earlier, we won't really be here. And like she has also implored us, I would also implore that please spread the news. Let's reach out to as many people, all right, as possible, because this information is life-saving will be life-saving to virtually every one of us. So thank you so much for making our time to be here with us. This is a once in a month event, so we'll be coming up next month again, and then we'll be expecting to have you here with us. All right, so I can see your hand up, Dr. Ada. You can go ahead.
Yes, thank you. I didn't know I was even on while I was making the call. Sorry, it's part of the planning. I want to solicit that we share our platform, the links that we have for the different platforms. One of our volunteers is going to make it available in all our WhatsApp groups. If we don't have enough people being reached with this message, I don't think we've achieved our aim. We've been getting very positive feedback. Part of it was what I was meant to share on during my presentation before my laptop hung. But I'll send them to the platform so that you know that what we are doing is making serious impact. Okay, and then we're also available to link you up at no cost to specialists, to professionals. There are a lot of people who hang around and say they are medical doctors, meanwhile they are not. So that is part of what we do for you at Health Hangout with Dr. Ada. Yes, we've had a few hitches here and there because we are just starting, we are neonates in the job, but I think it's getting better by the day. So why I took some time to talk is for our next meeting, I want people to suggest a topic. I've been the one providing topic, and that is not the idea. The idea is that the issues that bother you, we get you professionals to answer questions around them. So can you quickly type in the chat box if there is any issue you want us to discuss? Please, it's very important to me. I've been trying to say that during our WhatsApp meetings and share it on our WhatsApp platform, but I'm not getting good feedback. Only the volunteers are making suggestions. So do you have anything you want us, any topic you want us to dwell on next month, April? Kindly type in the chat box. Then while we're waiting to take this next month, or sorry, April or May, because for April, we are already looking at taking the most common cause of death in the world or in Nigeria and trying to demystify issues around it, and of course, avoid such preventable deaths. So that's what we're looking at for April. I don't know if you know the most common cause of death in the world. So I'll let you answer that question maybe in the WhatsApp group. So while we are waiting for that, please, I can see somebody's hand raised. Joy Chooks, please go ahead and ask your question now. Please type in the chat box what topic do you want us to deal with next time. Thank you. Can she hear me?
Yes, we can.
No, Joy Chooks was raising her hand. I thought she had another question. So I've not seen any topic yet.
I can see sudden pain in the shoulder.
I don't have, good evening everyone once more. I don't have any topic at heart, but why don't we give us some few days so that we can come back to the WhatsApp group and bring up these suggestions. I think it's quite impromptu for us to be able to come up with topics. Like me, I just joined today, so I didn't know the route and all those.
All right, that's fine. Somebody has typed sudden pain in the shoulder area. And I think one of our volunteers also sent something in that regard. So we need to get our orthopedic surgeons to join us. They're already waiting. Our doctors are waiting. They've showed interest in what we are doing. But I don't think we are doing so well. We should get more participants so that when they come in, they are happy to see that people are already on ground, ready to take the right information down to their circle, their family members and their friends. Okay, somebody say something on menopause. Okay, we're taking notes of these suggestions. Then, as I said, we can't cover all topics on cancer in one meeting. We missed out two important ones: breast cancer. The person that was meant to deliver that is in Canada, and she just couldn't make it because of her job. Then I actually omitted prostate cancer. Apology to the men. So, and other cancers. So we are planning for a repeat session, maybe sometime in June or July. We want to take a break from cancer and do something else. Yes, somebody said eating according to your blood group. Okay, so we are taking note of all these suggestions. Please, after the meeting, kindly send in your suggestions to the WhatsApp group. Then also help us spread the message. We will send in all our social media links. And then, as I said earlier on, we are lucky to have volunteers to help now. So it's going to be, the whole process is going to be smoother from now onwards. So please send in your suggestions and then we'll work on that. Somebody say family planning method. Okay, thanks. My moderator and my prof. If I forgot anything, please take it up.
So we are taking notes. Thank you so much, everyone. The most important thing we want you to go home with today are the preventive measures. All right, they are the preventive measures. Cancer is a bit depressing, it's scary, all right, but there are preventive measures. One of them said that I think the most possible way to avoid is not being born, but now we are born, so now we have to prevent. So please let us go by the preventive measures. God will continue to keep us safe. Thank you so much, everyone, and we appreciate your coming. So see you again next month. All right, bye, everyone.
Bye.
Bye. Good to see you guys and good to hear from you. Bye.
You can unmute your mic if you have to say anything as we exit the room.
Bye. Thank you very much.
Thank you very much for joining.
Bye. Thank you for teaching us today.
Thanks to our doctors. I'm just the convener. Thanks to my bosses for showing up. Yeah.
Bye.
Bye. If you have questions, keep sending them to my DM. I'll forward them to the specialist involved and get you the answers. Then if you have unanswered questions, please resend them. Now we have volunteers assisting us, so it's easier for me to handle the platform now. Yeah. Thanks again for attending. Please commit to spreading the message. We'll send in our social media handles, help us share it as far and wide as possible so that our professionals, health professionals, be encouraged to attend. Dr. Duka had to stay up at night, midnight. I wonder the time in US, at this time, just to talk with us. So let's encourage them by inviting more participants. Yeah. Thanks, and have a blessed week.